Thank you very much for the invitation to come and talk about everything about radiation, apparently. And I can come back tomorrow if you want, but I assume none of you will be here. And I'm also not going to go into specifics about sarcoma radiation or head and neck radiation. I'm a specialist in head and neck cancer, skin cancers, and sarcoma. That's primarily what I treat, but I'm going to do more of a global overview. I have no disclosures. And the topics I'd like to sort of cover in our 15 to 20 minutes is sort of what is radiation therapy. I mean, many medical schools don't even have a radiation therapy program. There's only about 85 or so academic ones. So a lot of medical students never see it. And when do we use it? What cancer types? How's it administered mostly? And then, what are the side effects of radiation? And so I want to open this black box for everyone to know what it is that we do, because many times we're down in the basement doing stuff and no one comes and visits. Fortunately, at the University of Colorado, we are on the first floor. And so there's different types of radiation. And you may see these in our notes, what we're recommending for things. And I got to use like the one PowerPoint symbol that matches radiation here with the lightning bolt. But primarily we use X-rays. These are photons, it's light. There's different energies of X-rays, the different energies. Megavoltage is primarily what we use to treat lung cancers, things that are deep into the body, head and neck, sarcomas, you name it. Orthovoltage, superficial, that's for skin cancers. It doesn't penetrate very deep. But those are all X-rays. It's the same X-rays that we use for a CT scanner or a chest X-ray, just much higher energy delivered with a different type of machine. Electrons, we can deliver those with the machines that we use for most day-to-day radiation treatments. You can think of them like little baseballs. They're a particle, penetrate into tissue and stop. We use those for superficial things, skin cancers, some breast cancer, boosting the cavity. Brachytherapy literally means short, it's Greek for short therapy. This is something where the radiation is delivered often with a radioactive seed, like placed in the prostate, or for cervical or uterine cancer. Sometimes we have a device that goes in the vagina to deliver the radiation very close, has a rapid fall off, so you get it really right on the area you want to treat. And then the next sort of section are the less common radiation, but certainly something that your patients may ask about, proton beam. Can I get proton beam? The closest protons to us are Scottsdale, Arizona, Mayo Clinic, University of Kansas has one now, University of Nebraska is getting one, and then University of Utah. So these are a charged particle, and they have some benefits that I'll show on the next slide, which is why a lot of people ask about them. But just overall, what you should know is the benefits may just be with side effects. So the side effects may be better in certain cases. To the best of our knowledge, there's no data or experiences or studies yet, mainly randomized, have shown a survival benefit to proton beam radiation. There's some percolating out there. In fact, one's going to be presented at ASCO for head and neck cancer randomized. And then neutrons, the only place in the country to get those is the University of Washington. These are like bowling balls that treat. They cause a lot of damage. We don't really use them for anymore. They primarily use them for salivary gland cancers, but our modern radiation techniques can treat those. And these actually blow apart nuclei and atoms and cause all sorts of damage. Then there's carbon ion. The first carbon ion is apparently going to go in Florida, at Mayo Clinic in Florida. This is even a heavier particle that has some biologic benefits in treating, where you can treat the lower dose. And then something that's really being newer advent is radioimmunotherapy. So this is, everyone's familiar with a PET scan. That's sugar. They attach a radioactive fluoride to it. You can image that. Well, you can take sort of anything and attach a radioactive isotope that emits an alpha particle or something that can damage a cancer cell, damage the DNA. And so that's really an active thing where you could really target this, put it on an antibody. And this is sort of a slide showing the types of radiation. Really what I wanted to point out here, the yellow curve here is the photons, the X-rays. They sort of just pass all the way through the body but decrease in energy as they do so, versus these charged particles, these protons. A single energy proton goes in, deposits at a specific depth. The trick with protons is that tumors are not 1 millimeter in size typically. They're bigger than that. So you have to use different energies to cover the full tumor, and that actually brings up the surface dose of radiation. So for proton beams, we actually see more skin toxicity than we do with X-rays. And what's the goal of radiation? It's to kill all the cancer cells and not damage the normal cells. This is actually what we call the therapeutic index, and now you guys could pass radiobiology boards because that's primarily what they want to know. So you want to kill all the cancer cells, so every last one. And the target that we're doing is the DNA in the cancer cells. That's what we need to damage with the radiation to kill the cancer cells. And we always give more radiation than we need, because the interaction of radiation with matter, particularly with DNA on a nanometer scale, I mean, a DNA molecule is 2 nanometers, which is times 10 to the negative 9, so very small. We have to give a lot of photons or protons or what have you to hit that target. And so this is, I did a PhD in medical physics, so this is justifying the 6 years of that. But how it works is this is ionizing radiation. These photons come in, or protons, and they basically knock out, a electron out of the orbit around an atom. And that electron goes out and knocks out more electrons. And then that causes this cascade that you want in the tumor that's going to damage the DNA. And the type of radiation we use are these X-rays, which this is the electromagnetic spectrum. There's our visible light and our microwaves that we heat our burritos with. And then up here is the X-rays. These are higher energy. That's how they do the damage and the ionization. And then how does it kill the cancer cell? It interacts with the DNA. And as I said, it's on this very nanoscale thing, and it's not always the radiation interacting directly with the DNA. We want to cause double strand breaks. That's very damaging. Single strand breaks, multiple single strand breaks. But most of the time, the way it interacts is sort of these indirect interactions. We basically create free radicals floating around the DNA, which then cause damage to the DNA, and the cancer cell can't repair that damage. Normal cells can. The issue here with this is, many times you might see a note in a radiation oncology talk about, we say don't take things that scavenge free radicals, and this is the reason why, because of this indirect interaction. And the Canadians, the National Cancer Institute of Canada, actually did a trial where they gave 20,000 international units of vitamin E weekly for people going through head and neck cancer radiation definitively, meaning no surgery, and these tumors were growing through treatment because basically the vitamin E was causing the radiation not to work. And then fractionation, how we give the radiation. You might see a patient and they're getting 1 treatment, or you might see a patient and they're getting 7 or 8 weeks of treatment, so 35 or so. And the reason is that not all radiation is sort of created equal in even how we deliver it. So this is another sort of radiobiology thing here, where on the right, this is what we call a cell survival curve. This is the number of cells in the tumor, and this is sort of our dose of radiation. And what you can see is 2 different ones. This is sort of a single high dose of radiation of 20 gray. Gray is our unit of radiation measurement. And this is sort of 10 fractions at 2 gray to 20 gray. But these are not equal. You can see at 20 gray, there's more cell kill with the single high dose of radiation there is when you fractionate it out. Now, the advantages of fractionating out is you allow normal cells to repair themselves and heal in between. And so, you can't treat half of a body with a single high dose of radiation because it causes a lot of toxicity. And we have different names for these that you might see in our consult notes. Stereotactic radiosurgery. This is a single high-dose treatment, often for brain metastases. Sometimes we call it fractionated stereotactic radiosurgery. That might be where it's up to 3 or 5 fractions. And then anything 5 or less we can call stereotactic body radiation therapy, or if you like Star Wars, SABR, that's another term for this. And this is ablative. So we often use this for like lung tumors as a definitive treatment, or sometimes in the oligometastatic setting where there's evidence that SBRT has a survival benefit over current standard of care systemic therapies. Immunotherapies kind of caused a new avenue there. We actually might see they can work together, this SBRT and immunotherapy, to cause systemic effects, what we call abscopal off target. Then hypofractionated is sort of anywhere from 6 to 20 treatments. Just means fewer fractions than conventional, and the conventional is 25 or more. And there's different external radiation techniques we use. This 3D, that's the older versions, but IMRT, or volumetric modulated arc therapy, VMAT, these are more conformal techniques that I'll show you a picture of that we often use more commonly for definitive or postoperative treatments. So, what are our goals of radiation? Our goal, it depends upon the situation. The majority of patients that get radiation often is in the palliative setting. Someone with a bone met that's painful might give 1 to 5 to 10 treatments to help with the pain. So a bleeding tumor, you might give radiation that can work very well to stop bleeding, because a higher dose can actually cause endothelial cells to apoptose and stop the bleeding, or you're trying to control something that's causing symptoms from control. We also use it in benign things, hypertrophic scars, keloids, certain fibrotic diseases like Ledderhose or Dupuytren's contractures, Graves' disease with the orbital involvement. And then in the world of oncology, we can use it preoperative, so neoadjuvant. You're trying to kill microscopic disease around the tumor. We use that in sarcomas a lot. The goal is not to make the sarcoma go away. In fact, sometimes it swells from inflammation during the radiation. The goal is to try to, when you go to surgery, when you resect it, there's a higher chance of negative surgical margins. Or you might use it postoperatively, and here we're trying to kill microscopic disease in the postoperative bed. Breast cancer would be the one that we do that most commonly in. Some other GI cancers or things like that. And then definitive. This is where radiation is the primary, there's no surgery. Radiation is the thing doing the primary heavy lifting here. And so in this, prostate cancer would be one where we use a lot of definitive. Head and neck cancers, we can use it there for that. And then this is just the recent American Cancer Society, sort of in the US, most common cancers. And so which of these are treated with radiation? Essentially all of them. Half of all cancers at some point receive radiation, whether it's in sort of a curative setting or palliative setting. And pretty much all in here, you might say, like, what about leukemias? Well, we sometimes use it for conditioning before a stem cell transplant, or for like the testicles when they can be a site that chemotherapy doesn't reach to treat. We use it in thyroid cancers if there's after surgery. We use radioactive iodine, which is technically radiation, but sometimes use external radiation too to kill microscopic disease. Now, how do we deliver this radiation? Well, we use this machine called a linear accelerator. That's our workhorse for X-rays. So you can see this design hasn't changed in literally like 40 years, but the sort of what's back underneath the surface has, but the radiation comes out of here. This is the head. There's little leaves that shape the radiation, and then the patient lies on this, we call it a couch or a table. It's kind of unfair to call it a couch. It's not very comfortable. And then the machine actually rotates around to deliver the radiation. These things on the sides are actually imaging devices. We can do low-dose CT scans to image, so we do image-guided radiation. And then this couch, this tabletop, can move in sub-millimeter resolution. It's robotically controlled. And then what's our workflow from radiation? Well, we see the individual in consult, talk to them about what the radiation is, side effects, why we're doing it. And then at some point, shortly after that, sometimes the same day, we do what we call a radiation simulation or planning session. This is when we map it out. So it's usually CT guided. Sometimes we make molds, like head and neck cancer, we make a mask to keep them in the same position every day, do a CT scan, and then we draw this out where we're gonna treat, literally, very much like a surgeon, but instead of a scalpel, we're using a computer mouse to draw it out. And this time period is actually where it takes longest. During this sort of in between the mapping session and the treatment, it can be up to 2 weeks for more complex plans with IMRT, or if it's something palliative, it could be same day sometimes, or at least in 2 to 3 days. And then during treatment, that can be as long as one treatment, as I said, or 7 or 8 weeks, and we see people weekly during treatment to address side effects as they come up, very similar to administering chemotherapy. And then this is an old way of doing a simulation for radiation for head and neck cancer. It was basically an X-ray, and then it literally took 15 minutes to draw this stuff out. We drew out the lead blocks, and here they're drawing out some lymph nodes on either side. They draw out the larynx, but you're sort of treating through and through, and you'd often have to move off the spinal cord at some point. And then intensity modulated radiation therapy was invented, where the one below here is the old way, where you can see you're just heating up everything, salivary glands, things like that, versus when you use the IMRT, you can do this more conformal thing, where you can actually shape it out, carve out salivary glands, throat, swallowing muscles, voice box, and spinal cord. It does take more time to plan and do quality assurance. We actually do dry runs to make sure the doses are correct on the machine. But it allows us to even paint the radiation dose. And what I mean by that is if there's gross tumor there, lights up on a PET scan, you can give it more radiation. But if you're worried, like a surgeon would do a neck dissection, a head and neck cancer patient, they're removing all the lymph nodes plus microscopic disease, well, we would, if they're not getting surgery, we treat that to a lower dose, which allows a lot of different ways. And then why is this IMRT important? This is a randomized trial in head and neck cancer from the UK, where they said, let's do it the old way versus the new way with IMRT, and let's look at side effects. And here they looked at basically dry mouth, so salivary function. So in one, they're able to spare the salivary glands, parotids and submandibular. And what you can basically see is over a 2-year period, the people treated with the older radiation basically had no recovery of salivary function, versus the people that had IMRT it basically recovered over a 2-year period. And when I see people, I say that the dry mouth from head and neck cancer, speaking of side effects, is the longest one. You can see over 2 years keeps getting better and better and better, so there's that recovery. And then what are the side effects? I could spend an hour on this, and it really depends on where you're treating. And so location is the most important thing. What's nearby? Are you treating the lung? Is it near the heart? Is it near the esophagus? Are we worried about esophagitis? Are we worried about pericarditis, inflaming it? And then how deep are you treating? If it's a superficial thing, you're not going deep into the tissue. But if it's, let's say, in the heart, I treat heart sarcomas sometimes, now you're way in there. And then you have to look at the chronicity of this. There's short and long-term side effects of radiation. Some of the short turn into long-term. And they recovered differently too, but you can sort of see like maybe a pain flare from treating a bone met might be 24 to 48 hours before that's gone, versus let's say the salivary function can take years to get better, versus mucositis or something, or esophagitis might recover over a 4-week period after things are done. Just for you guys, most common general side effects: tiredness. Radiation, almost any part of the body, causes fatigue. Best medicine for that is being active, exercising. If you're treating anywhere basically in the gut, nausea can happen. Antiemetics like Zofran, that's FDA approved. Radiation passes through the skin, so you can get radiation dermatitis, basically a sunburn. And then I mentioned the pain flare, sort of a bone met, you get inflammation, it swells and it spot and it hurts. And you can use steroids for that or pain medications. And we usually alert the patient to be prepared for this. And then, so that's it for that. So any questions? I guess we're not taking questions, but yes, we are. Gamma knife. Okay, so gamma knife, that's a radiosurgery technique. It was invented by a neurosurgeon in Europe, hence why it's surgery, but there's no surgery involved. And gamma knife we still use today. It's a cobalt source, actually multiple, and you could sort of think of, they basically screw someone's head, and it's literal, screw it into a frame, and then stick them in what looks like a colander, and you're able to do these pinpoint radiation beams, so you can treat micro, like 1 millimeter tumors in the brain. Really is it's for the brain to sort of treat that area. But we still do use that. And now there's actually gamma knives that you don't have to screw it in. They have masks that are multi-fraction. But Linac-based radiosurgery is the same. You can get the same outcomes.
And the Hulk, where did he come from?
The Hulk, yes. That's gamma radiation, which we don't really use. So it's X-ray.
How long after radiation is complete can you still see these side effects develop?
Yeah. So it depends upon what you're doing. So the shorter courses of the radiation, the SBRT, oftentimes it's abbreviated. It can be like 1 to 2 weeks after the treatment ends, they get the side effects, actually. They're a little delayed. And then 2 to 4 weeks, they resolve. Let's say 7 weeks for a head and neck cancer, the sore throat, the taste changes. That builds up over time during the treatment, peaks a week or two afterwards. That's sort of the cell turnover. And then that can take, I usually say pain, mucositis, 4 weeks. The epithelial lining heals in about 4 weeks. Same with skin. But dry mouth, as we just talked about, can be months and stuff. And then throwing other things on board, I didn't mention that, like adding chemotherapy. Like during radiation, that increases side effects. After radiation, things like doxorubicin. That is one of the most potent radiosensitizers we use. We do actually use it concurrently in certain cancers, anaplastic thyroid cancer, but at a lower dose. But sometimes you can have radiation recall. And so that is like a year later, you could do radiation or do, let's say, adriamycin. And if someone got radiation to their throat, it'll just cause the mucositis to recall. And we've seen it with immunotherapy. And we actually have seen it with COVID. So there's some reports in the New England Journal of Medicine, actually one from our Dr. Rachel Rabinovich, who treats breast cancer. Someone got COVID, and they had been treated 5 years earlier with reirradiation of the breast, and the whole radiation dermatitis showed up. Like that, you had to use like wound care. And it was purely from COVID, so. Any other questions? Oh.
Hi, Dr. Lanning. So I had a question about the dental for head and neck cancers.
Yes.
Because, I work at the VA and the Oncology Nurse Navigator, and we kind of have a little differences with how to, regarding teeth extractions before treatment.
Yeah.
And I heard this a little controversial, but I just kind of need some guidance.
Yeah, this is a load topic. As we saw that picture of old radiation, treating straight through the mandible. I mean, the mandible was getting the same dose of radiation as the tumor. which back then you couldn't really control where the hot spot was, so tumors are getting 80, 86 gray when you only today want them to get 70. So the mandible is getting that. So you saw this osteoradial which could happen on its own, or someone extracts a tooth and it doesn't heal. And so back then it was reported in 15, 20% sometimes of cases. And sometimes surgeons had to go and repair that. Now today with modern techniques, we're able to spare the mandible dramatically. And even, unless the tumor's invading into it, we just don't see it anymore. I actually have not, the osteoradial I see is usually an oral tongue cancer where the mucosa is not healing over the mandible. It's not that someone's having a necrotic bone in their mouth or anything. And then we've discovered, and it came out of UNC, where they looked back at people that got prophylactic extractions. And so you go see the dentist, and they're like, well, I'm worried about this tooth someday, so we're going to pull them out. So the people that got prophylactic extractions actually had worse dental complications than the people that didn't. And so we sort of do more conservative management of that. And then another thing that comes out of dental is a lot of dentists talk about a golden window, which is the month after radiation is done for head and neck cancer, you can do whatever you want to the mouth. And so I was very perplexed by this because it made no sense. And so I eventually found the original paper from the 1980s, back when they drew out the graphs on graph paper, where they talked about not the golden window, but they just showed when there were complications from radiation. And the curve started at 1 month because no one's going to their dentist during the first month when they don't want anything in their mouth. And so there is no golden window after radiation. But so long and short of it is osteonecrosis today is less than a couple percent. We just don't see it. We've kind of stopped doing prophylactic extractions. The way I counsel the dentist is if you would pull the tooth if they didn't have cancer, then pull the tooth. If not, and usually we wait a couple days before we start the planning for the radiation, because it takes 2 weeks to start. But yeah, so that's the way I counsel. We just don't see it as much anymore. That was a long explanation, sorry.
All right. Thank you very much.
You're welcome.